Thank you, Sherry. And I just wanted to thank the organizers of this meeting. It's been a really wonderful learning experience, and we really appreciate being invited to share our work in Boston. I'm going to build on what Sherry said from what the hospital is doing to the system level work. She kind of ended up her piece on some of the system level work that they're engaged in, that we're all engaged in, and kind of talk more about what we're doing in Boston and Massachusetts to build that infrastructure where we have quality services that the medical system will pay for. So the Boston Public Health Commission has actually conducted asthma home visits for quite a long time. Sherry really spoke to the inequitable outcomes that have been driving a lot of this work. Around 2008, with a lot of evidence emerging around the outcomes and what should be the components of an effective home visiting program, the Health Commission really decided we needed to revamp our program to make it reflective of the emerging evidence. But as we did that, we did a little bit of a needs assessment. We interviewed clinicians that were making referrals for asthma home visits. We interviewed I don't work for a clinical setting, so I call people clients when we serve them, but we interviewed our clients, and we also interviewed organizations in Boston that were conducting asthma home visits and were maybe involved in them in some way. And so coming out of that, we found a few things. Programs came and went because they were grant funded. Now, when programs come and go, it makes it very hard for a clinician to make a referral because they don't know if it exists. The other thing is that programs, there were actually a decent amount of programs doing home visits in Boston, but serving very specific groups of people, whether it was their patient population or a geographic area. And we really did have some particularly lingual and geographic communities that were underserved. And then the clinicians were very confused by all the different services and all the different providers. And out of this, we really reached out to a number of organizations and brought them together to consider having this collaborative to develop a home visiting system for asthma in Boston. We early on developed a vision, and we wanted the home visits to be consistent and high quality across institution, and that they would ultimately be paid for by those sources that pay for traditional medical care. We wanted to build capacity to offer these visits in as many languages as needed. Boston is a very diverse city. And we wanted to establish a centralized referral system. The thinking behind this, and we have done it to some degree, is that no one institution can serve every, particularly lingual community. So we do, when referrals come into the commission, for example, Children's Hospital has a Cape Verdean Creole home visitor, and we will make those referrals because we can't do it ourselves. And we helped to build a program in Boston's Chinatown neighborhood, which serves a population that, really no one else had the ability to provide this service for them. We've had a fairly stable participation since 2009. The Commission really convenes the group. Boston Children's Hospital has been there from the start and really has provided some funding and a huge amount of human resources in terms of expertise. Boston Medical Center, which has a home visiting program, has been very involved. The Environmental Protection Agency has always provided a small amount of funding to, so that we can manage the collaborative, and they have had their regional asthma manager participate since day one. We do have, Neighborhood Health Plan is a New England-based plan that has a large Medicaid population, and they do pay for these services. They don't necessarily pay the cost of the service, but they do pay for them. And then Partners Asthma Center. Partners is a large health system in Boston. And Tufts Medical Center, which is located in Chinatown, and we're really pleased. We were able to get a grant from the HUD Healthy Homes to really help them start their program, and we have a manuscript in redraft form showing the health outcomes and showing the participation rates from their patients. So their hospital has actually institutionalized funding for that. So we're very pleased with that success. I said that EPA provides some funding, and one thing it's allowed us to do is have a facilitator who is an asthma policy expert. And it really has been critical because our collaborative, who runs the collaborative, makes the large decisions, involves many strata of this sector, including clinicians like Dr. Nethersall, public health administrators, myself, but all the community health workers that are conducting the asthma home visits are also full participants in the collaborative. And having a facilitator really allows us to be intentional about making sure that every voice is heard always. We stole from existing evidence-based home visiting programs like the Seattle King County program. We tested forms, we revamped them a little, data collection forms, and our educational materials, so that we all agreed on the same materials. I think that took us like 3 years, really, but we started developing a system of support for the community health workers who perform the visits. We completed a pilot evaluation of clinician and client satisfaction and asthma control test improvements after year 1, and we completed a second evaluation in 2013. So, community health workers tend to have very stressful jobs and often work in isolation, and support and integration is actually shown to impact retention. So we have a monthly meeting of the community health workers. It's usually a nurse practitioner, Susan Summer, who's from the Community and Asthma Initiative at Children's, who attends every meeting to provide clinical oversight. The community health workers are reinforcing individualized medical management. So they are talking about exactly which medications their doctor thinks they're taking, and how to take it and when to take it. So, as well as doing some level of motivational interviewing and environmental assessment and referral. So the skill and knowledge level is pretty high, and maintaining assuring quality is really important. And then they do peer-to-peer learning and problem solving. And then resource information has become really critical to them. They tend to invite a speaker to most meetings. The context that people live in is just really complicated. We are the third most expensive rental housing environment in the country. Our public housing is among the oldest in the country, and we're one of the oldest cities, so our non-public housing isn't that great either. And so housing stability, energy, heat stability, food security are really immediate issues for people, as well as many other ones. And what the community health workers do is they have to know all the resources, and they have to have those relationships so that they're making referrals. And really what they find is that until they can help the family with what the family identifies as their very real, very immediate, very urgent issues, then asthma is not going to be the priority. So they do a huge amount of housing assistance, food stamp assistance, and they have some level of being able to start enrollment processes. While we've been doing all this in Boston, our state Department of Public Health, the Massachusetts Department of Public Health, had also prioritized universal access to quality community health worker-led asthma home visits across Massachusetts. And two of their areas for action were achieving insurance reimbursement and driving demand among payers and providers. And those are our home visitors from a bunch of different agencies. So I do want to stop right now, and I want to acknowledge our Massachusetts Department of Public Health, because they gave me permission to use 3 of their slides and talk about the work that we're doing with them. So these were actually developed by the DPH. The Department of Public Health did a competitive bidding and selected the Boston Public Health Commission about 4 years ago to develop a training and support system for community health workers doing these home visits in Massachusetts. And the training and support is really undertaken by 2 parts of the Public Health Commission: the Asthma Prevention and Control Program, which is in the division that I direct, and our Community Health Education Center, which is essentially an area health education center. It's a center that's designed, whose mission is to support and do skills development for community health workers. Within the past 4 years, we have developed and refined and continue to refine a 4-day asthma home visitor training. And in addition to that, a 2-day annual refresher. The Mass Department of Public Health requires now that programs that they're going to fund do the training and also participate in the Comprehensive Outreach Education Certificate Program that in Boston is offered by CHEC and in other parts of the state are offered by other organizations. Because a lot of organizations aren't necessarily familiar with working with community health workers and integrating them into their system, we also provide a 2-day supervisor training, and then sort of modeled on what Boston has done, we offer quarterly support meetings as well. And Dr. Nethersall mentioned the regional CMMS-funded New England Asthma Innovations Collaborative, and we have also been funded to offer these services to the collaborative. So the DPH, they're in their strategic plan, their asthma program, to create a system of asthma home visiting that was funded, hired a consultant, Terry Mason, to conduct a needs assessment and to make recommendations to the Asthma Prevention and Control Program. As part of her needs assessment, she interviewed the payer community. And what she found was that there was some openness to payment, and some are paying, but some still wanted to know more about cost benefit and needed more evidence that it worked. And there were very specific suggestions coming out of that group as well. Standardized training, which we had already, was well underway, but also a standardized skills assessment and evaluation for the community health workers, and then an easy referral system. So their recommendations were to expand the training and include a mentorship or practicum phase. The Health Commission has been selected to oversee this mentorship phase. There are high-functioning asthma home visiting programs throughout the state of Massachusetts. We're not the only game in town. And so we are identifying programs that we can partner with other programs in their area to mentor new community health workers. And Sherry and I were speaking earlier about our experience. A number of us have been informally mentoring programs for a number of years, and it really can take 6 months for a community health worker to be fully competent to conduct these home visits independently in the field. So this is, you know, one of the things I've been thinking about all day is, like, in a sustainable system under, you know, payment models, like, who's going to pay for that? Like, I don't know. We're also working with the DPH to develop this performance-oriented assessment that will include home visit observation. And they did recommend one model that's similar to the Boston model, but, you know, around having coordination, so you kind of have regional capacity rather than just institutional capacity. I mean, Boston is healthcare rich. We have a lot of healthcare institutions. So that model really is a good fit for us. Other parts of the state, and certainly other parts of the country, it might not be the perfect model. You might have one health center and one hospital. But the other thing that our state is working on that I think is really important to this is piloting e-referrals. So hopefully, you know, I think that the end goal is, can it come out of the EMR? But right now they are piloting electronic referral from clinical sites to community sites for services and then information back. And that is all I was going to say, but do you want me to say a few words about Boston Breathe Easy at Home? Sure. Is that great? So Terry, there is number 8 in your sources link is an article, a Journal of Environmental Health article about Boston Breathe Easy at Home. And Boston Breathe Easy at Home is a program we've had in place in Boston since like 2006, and it allows clinicians from their desk to make online referrals for home inspections, for code enforcement inspections from our Boston Inspectional Services Department for their patients with asthma. And then they get notifications when there are updates about has the inspection been scheduled, has what was found, is it going to court, is it resolved, and they get a notification by email, and then they go to a protected site to see what the actual information is. So the article that the link is very descriptive. Some other communities, the state of Rhode Island has adopted it. We currently have Robert Wood Johnson Public Health Systems research funding to evaluate it. If you are a city that has a housing code and has a housing code enforcement system in place, it's very doable. It is very challenging because often somebody, you know, they might tell Dr. Nethersall, sure, send a housing code inspector to my house, but that's not necessarily, you know, what they might feel afraid. But we, with the public health systems research, we have undertaken a failure modes effect analysis as just one part of our evaluation, where we're going through every step of the referral process and identifying where the opportunity for failure is, and then assigning risk to it. How many people would this happen to, and what's the risk if it happens? And then we have been able to actually prioritize interventions to really improve the program. I think Terry asked me about how many go to, how many get resolved outside of court, and it's 70%, which is not different than what they do anyway. And one more thing, and then I'll be quiet, but thinking about multi-sector collaboration. Early on, we found that our Boston Housing Authority, our public health housing agency, was a lot of those referrals were for their housing, and they are part of our steering committee, and they signed a memorandum of commitment with our code enforcement agency a number of years ago that says they will respond within 24 hours to these complaints, and they have a liaison, so when things don't get resolved, and they don't often, that we have a human being in their operations management that we can go to and say what's going on.